Welcome back, everybody. Welcome back. This plenary session is called Competing Visions for the Future of Healthcare. And my only job here is to introduce the moderator, who is Larry Levitt. And before I do that, let me just make a couple of announcements. This session is going to go until 5 o'clock. And then there's a couple of events going on tonight that we would encourage you to go to. We designed them because we think you really enjoy them. Following this session, we're going to have a screening of a documentary. We've mentioned it a couple of times before already at this conference. It's called Remote Area Medical. It's about a health clinic, a pop-up health clinic, massive pop-up health clinic, and some of the people who go to get free care. And that's at 5 o'clock in Columbia B, down here. Starting at 6:30, we're going to have an awards reception right here in the ballroom, and we're going to honor our Health Equity Advocate of the Year and our Health Advocate of the Year. So we typically have done the awards reception at Friday lunch. We're doing it a little bit different this year. We're going to have it as a reception, a little bit more glitzy and glamorous. So with that over, let me introduce to you the moderator of this session, Larry Levitt. Larry is the Senior Vice President for Special Initiatives at the Kaiser Family Foundation and the Senior Advisor to the President of the Foundation. Among his other duties, he is Co-Executive Director for the Program for the Study of Health Reform and Private Insurance. Previously, he was the Editor-in-Chief of KaiserNetwork.org, the Foundation's online health policy news and information service. And he directed the Foundation's communications and online activities in its Changing Healthcare Marketplace project. Prior to the Foundation, Larry had a career where he served as a Senior Health Policy Advisor to the White House and the Department of Health and Human Services, working on the development of President Clinton's Health Security Act and other health policy initiatives. He was a Special Assistant for Health Policy with the California Insurance Commissioner John Garamendi, and he has also held numerous positions in Massachusetts state government. So with that, let's welcome Larry Levitt. Thank you.
Thanks, good afternoon. And I know we're probably the only thing standing in between you and cocktail hour, so we're going to mix this up a little bit and keep it lively. We're going to talk about the future of health reform, and in some sense the future of health reform, or specifically the Affordable Care Act, is at the same time more secure than it's ever been and more insecure than it's ever been. The website meltdown is thankfully behind us. Millions of people have signed up for Medicaid and for the marketplaces, and premiums are growing at very modest rates. On the other hand, the Supreme Court is about to consider a case, King versus Burwell, that could completely upend all of this, and Republican opponents of the ACA have taken control of Congress. So we're going to consider the opportunities and the challenges ahead and do it from two different perspectives. On my left, appropriately, is Judy Fader, who's a professor at Georgetown University, a former health official in the Clinton administration, and chaired the Pepper Commission, directed the Pepper Commission, which was chaired by Senator Rockefeller.
Yes, be very careful of that.
Right. And also appropriately on my right, we have Joe Antos, who's a scholar at the American Enterprise Institute and previously worked at HHS, OMB, and the Congressional Budget Office, among other places. They're both very smart observers who have been through a lot of health policy battles, and they're two people who are listened to very closely by policymakers. I figured I could introduce these two and let them talk or maybe with each other for an hour, but I'm not going to do that. I'm going to corral them in a bit. And we also have question cards around the room, I think, so if you have questions, we'll try and squeeze a couple of those in as well. So I'm going to start. We're now in year 2 of the Affordable Care Act, although in ACA land, I think it's more like dog years. It feels like 10 or 15 years to me. But it's time to I think it's sufficient time to take stock. So Judy, let's start with you. How is the ACA doing from your perspective? Is it doing what it set out to do?
Well, to be perfectly candid, which I aim to be this afternoon, I have been astounded at how successful the ACA has been. You know that I've been an advocate and an analyst trying to get coverage expanded for a long time, and to the fact that we have covered about 10 million people, that premiums are rising more slowly than anticipated as insurers compete for enrollees, and that we're doing this all in an environment of historically, again, astoundingly low rates of growth in healthcare costs I think is an enormous accomplishment, and I think you all should give yourselves a hand.
Any surprises?
Well, all of that's a surprise to me. I mean, we surely didn't make it easy for people to sign up. I think it's evidence of how that it's been this successful in expanding coverage to people who didn't have insurance coverage is evidence of how very much people want health insurance. And I've always wanted them to want it and wanted it for them, but I'm impressed to see to what lengths people will go when we don't make it easy to get coverage.
Joe, how do you think things have played out? Is it what you expected?
Well, it's hard to know what to have expected because this was a gigantic change that truly was unprecedented. It depends on which numbers you look at. I'm not as impressed with enrollment. The administration released information that as of last week sometime, they said 7.1 million people had selected plans in the exchanges. And that seems like a pretty big number, except of course that's about as many as signed up for 2014. So they actually haven't made any progress there. And there's only, it was as of the 16th, so effectively there's only 1 month left. Now, of course, there will be a bump in, as there always is, people put things off. My favorite date for taxes is April, well, I'd like to say 15th. But you'll have the same kind of phenomenon. But unlike last year, I don't think you're going to get anywhere near the surge. So I really think if you look at those numbers, enrollment, I think you're probably going to end up with not very many more people enrolled through the exchanges than you had before. The other issue is, it's not how many people enrolled in the exchanges, it's how many people didn't have coverage who got it through this legislation. And that is truly hard to know at this point.
Do you think people have gotten coverage? You're just not,
oh, yeah.
You're just not sure how many.
Well, that's important because, of course, we're spending hundreds of billions of dollars. We've already spent hundreds of billions of dollars. So we don't really want a program that costs, well, nearly as much as I think it's costing per new person enrolled. We'd like, if we're going to have programs, we want them to be a lot more efficient than I think this one has been. Now, I'm not saying that it can't become more efficient, but I think it's going to need some changes.
So, Joe, and back to Larry, your question about whether there were any surprises. One of the concerns that I had was that the enrollment would be dominated by people who previously had coverage, and that we would not make as much progress on the newly insured. And so, obviously, Joe, you're talking about the challenges of sustaining and advancing the progress in the first year. But, and yes, measures are imperfect, but about 10 million newly insured, that's a pretty damn big number.
Joe, are you?
Well, you're including the people who sign up for Medicaid.
Absolutely.
Yeah, sure. So, and what we don't know is how many of them could have signed up for Medicaid anyway. I mean, there are a lot of questions we can't answer.
No, well,
Yeah.
Okay,
I mean, 10 million. Look, considering
newly insured.
Considering the hundreds of billions of dollars just spent in the past year.
It's the reduction in what I'm reporting on is the reductions in the numbers of uninsured.
Yeah. Now, Judy made the point, which I thought was a good point, in your opening remarks, that what last year's experience showed was that people who really wanted insurance were willing to go through an awful lot to get it. I think that's a really good point. I think the problem is that insurance, whether it's health insurance or homeowners insurance, doesn't work if the only people who sign up are the people who really need it. Yes, healthier people have signed up, but I think that's an ongoing concern in the future.
Sure it is. But then when you look at the response of the health insurers, and that we've got even more participating this year than we had last in the marketplaces, that they're lowering their premiums, that they're still keeping them low so that they can attract enrollees. I don't think anybody's better than they are at guesstimating what they're going to get in risk.
Well, of course.
And so they're betting on success. Yeah.
Okay,
You know,
let's
it's a business. Larry, we're not going to let you talk very much.
No,
but,
no, you are. You are. Let's call round one a draw.
Okay.
We've been talking about how many people have signed up, who those people are, and why they've signed up. Putting aside Medicaid and looking at the marketplaces, the subsidies that people get, the tax credits, are obviously a strong inducement to get people signed up. And there's a disagreement. I think we're going to have a debate now with the Republican majority in Congress about whether those tax credits are too generous and should be trimmed back, or not generous enough and leaving people still with unaffordable coverage. Joe, do you think the tax credits are too generous? Should they not go up as high up the income scale as they should?
Well, the whole question of federal subsidies for people to either get health insurance or health care is a much broader question than these premium tax credits. And so I think we really ought to take a look at more generally. I tend to think that we are over-subsidizing people who need less help, and we're under-subsidizing people who need more help.
Meaning lower income people?
Right. We have this very generous employer tax exclusion, and even though there is the Cadillac tax, which has encouraged large employers and insurers to change the way their plans go, and Harvard's very upset about that, nonetheless, it's still the case that higher income people get more benefit out of that than lower income people, and that's a huge amount of money. It's something like $350 billion a year. So, if we were to look at that, I'm not saying that Republicans could do this either, but if we could look at that, and we could look at these other subsidies and look at Medicaid subsidies and ask ourselves, how is this actually being distributed, and do we want to rearrange it so that it is more effectively targeting the people who need the most help? I think that would be something to work on for the next 2 to many years.
50 years.
Yeah.
Judy, do you think coverage is affordable for people now with the Affordable Care Act?
Not enough. I don't think so. And I hear Joe indicating that he thinks we could do better by low and modest income people. The Affordable Care Act subsidies are not particularly generous. They charge premiums to people at very modest income levels. And even though the cutoff at 400%, 4 times the federal poverty level, may sound like a lot, healthcare is expensive. And if you look at what it costs older people, since premiums can still be age-rated, older people to pay for unsubsidized premiums, it's over about $7,000 on an income of $45,000, a lot of money. So I think that that's a significant problem in terms of participation, and I'd also draw attention to the fact that the subsidies for cost sharing stop at about $30,000 for an individual. I think that's right, and that cost sharing that we're seeing a lot of high deductibles, higher in the marketplaces than in employer-sponsored insurance, and we know we've got lots of evidence it's a real barrier to affordability of care.
So Joe brought up employer coverage and the subsidies for employer coverage. That's one of the more controversial parts of the Affordable Care Act, the requirement that larger employers provide coverage to their workers or face a penalty. And that was one of the first bills passed by the House in this new session, was to change the definition of full-time workers under that requirement from 30 hours a week to 40 hours a week. What do you think? Is that a step forwards or a step backwards to change?
Well, I think the concern in terms of where that line is set are the incidents we hear or complaints or concern that employers are cutting hours in order to stay under that that threshold. And if where that is happening to people, that's a bad thing. But the evidence tells us it is not happening on a large scale. And whenever we draw lines in public policy, which you have to do when you establish rules and subsidy schedules, et cetera, and requirements, it's tough. And this line was drawn at 30 hours to avoid affecting a lot of people. And about 80%, I think it is, of workers, of hourly workers, are working more than 35 hours. So to the extent that it's affecting people, the effects are limited to a smaller segment of the workforce. As I said, we don't have evidence of a lot of it. If you raise it to 40 hours, then you're potentially affecting most workers. And a lot of things affect the decisions that employers make about full and part-time and how many hours. It's not just about the health insurance benefits, because it affects the way the businesses operate. But if they're affected by it, then we'd have a whole lot of people losing hours based on this rule, and that, I think, is a big problem.
And how about the employer requirement in general? I mean, your fellow advocates of the ACA are somewhat split over this, whether the employer requirement should be repealed or is an important part of the core part of the law.
Well, the way I understand the employer requirement is it is a part of the overall design of the ACA, intended to signal and to operate as not a replacement for employer-sponsored coverage, but to leave it intact and work around it, fill in its holes. That's, I think, what the law is, the way the law operates. And so that's why the requirement is there, and the penalties do contribute to funding the law. That said, the analysis tells us that the employer requirement is not what's driving coverage. What drives coverage through employers and has always done it, is the fact that we get a tax benefit when our employer-paid premiums are not subject to income tax or payroll tax the way wages are. And that built the employer-sponsored insurance system, and that's the way most of us get coverage. So the general argument is that it would have, or the analysis is that to eliminate it would have a weak effect, if any, on coverage, but it might have some. The penalty, as I said, you need to find an offset for getting rid of those penalties, and there is a concern about what it's signaling about the shared responsibilities in getting everybody health care. So I think it's a matter of concern.
So Joe, your fellow critics of the ACA have been somewhat split on this narrower issue of changing the definition of full-time work. Do you think it's a move in the right direction to do that, to change it to 40 hours?
Well, let's consider what the employer mandate is really all about. It was actually to get a good CBO score. That was the real purpose. Because with the employer mandate, the argument was, well, there would be millions of people who would stay in the employer-based system, even though if they were not restricted that way, they would have been eligible for potentially very substantial subsidies in the exchanges. So this was a pure Washington political ploy. The fact is that large employers are not going to get out of the business of offering health insurance to their employees. Small firms have trouble doing that because they have a hard time, frankly, staying in business. So you have to decide, do you really want to force this on people, given that, in fact, we know that there are people who would do better in the exchanges with the subsidies than they would through the employer
lower wage workers.
Lower wage workers, exactly. And the other point is, when you think about these poor people who are working 40 to 44 hours and they might lose a few hours, okay, fine, maybe. But 90% of them get employer coverage. So we're not really talking about that many people. Whereas if you're a 32-hour worker, and we know who a 32-hour worker is. These tend to be lower wage workers in industries like the food and beverage service area. Well, these are people who need every hour they can get. So this is just a really terrible idea. The whole thing is a terrible idea, but putting it at 30 is really a triumph of, I would say, political ideology over reality, which is that the people you want to not hurt are, in fact, the people most likely to be hurt under this thing. Now, moving from 30 to 40, well, you know how it is. If you don't really understand how it works, then that sounds very attractive if you're inclined to make some changes. But I think it's really not a very smart idea because it still leaves in place all kinds of reporting requirements. That is the reason why the administration pushed it off a year, because the fact is that even large firms couldn't figure out how to report. This problem hasn't been resolved. So I would argue that complete repeal, if you're going to fiddle around with the pieces, go up one notch and take out the employer mandate. Even the people who originally supported it agree that it's really not doing what you want it to do.
And how would you, if you got rid of the employer mandate, it would cost the federal budget maybe upwards of $150, $200 billion. Would you replace those dollars to avoid increasing the deficit?
Well, that is up to those who wanted to have such an expansive and generous set of subsidies in the first place. Remember, my theme is, let's look at all the subsidies. Let's not just compartmentalize it and say, oh, no, well, you got to find $5 here and $5 there. No, I think it's a much bigger problem. We need actual reform.
Okay, fair enough. Let's turn back to Medicaid, where we started. So as people in this room well know, upwards of half the states have not chosen to expand the Medicaid program. Judy, put on your crystal ball. Do you think governors are going to expand over the next few years? And it seems that the expansions will come from red states who may look to do things a little differently in doing the expansion. And what should the federal government be looking at in reviewing those alternative approaches?
So, ever optimistic, I believe that the Affordable Care Act, which is now the law of the land, is going to stick. People are getting benefits. It's hard to take them away. The Supreme Court notwithstanding. And as that happens, it seems to me that it becomes harder for states to resist the money on the table. The politics of this or the value of it just seems to me questionable. Ultimately, reality of getting all that federal money in to both get people health coverage and to support the revenues and the economic growth in the state just makes too much sense. Now, easy for me to say I have health insurance, so you know it is any people left out for any period of time is highly problematic. But I think they'll come in, and I think that the strongest force, in addition to people in this room and our allies across the country, I think the strongest force is not that people are going without care. It is that providers see this money going on. That's right. They just do not like that. That just doesn't make sense. So I think that's a good thing. That said, and maybe consistently, coverage, I think that we want to get people covered sooner rather than later, but I don't think it's accomplish it at any price. So when looking at the proposals from states for waivers under which to cover folks, I think there's some really very important lines to be drawn. I think that we know that making people pay more in premiums or cost sharing means that people they don't get coverage or care. That's a real problem. And I think work requirements are just bloody unacceptable in a health care program. And I think when you look at the proposals that come from governors or the rhetoric in the states, they're not arguing that markets are more efficient and they want more efficient markets. They're just bashing the safety net. They are really arguing, like as Paul Ryan has, that it's a hammock and we should diminish it. And I don't think that we need a stronger safety net. We can't sacrifice it.
So Joe, if you were a governor, let's say, and had not expanded Medicaid yet, how would you look to expand? Would you try and expand, and how would you try to go about it?
Well, you know, it's not entirely clear. You know, part of the problem is, as Judy said, the hospitals really want their money. Let's face it. This is true in every state. You know, if you were a conservative-minded, market-oriented governor and you had support from a legislature, which often isn't the case, but if you did, then I think you'd look for something that might be you know, on the order of Healthy Indiana, for example. Something that gives people an opportunity to really feel ownership over their health insurance and responsibility. And I'm not talking about Healthy Indiana 2.0. I'm talking about Healthy Indiana 1. That's the one that I think really gets at this point. So, you know, one of the reasonable principles, I think, is don't take money away from people, but give them greater control over how it's spent. They might not want to spend it the way the Medicaid program or the hospitals want to spend it. Give them something like a health savings account, and don't expect them to contribute to it because they're poor people. Put some money in there. And that will get them more involved in asking the questions that everybody ought to be asking. The classic one being, gee, do I really need to come back next week? This is especially an issue for maybe for elderly people, but my mother, you know, her doctor or her doctor's staff would say, well, you know, you have to bring your mother in next month. And you know, she's perfectly healthy. Why should she come? And the answer was, well, we need the money. Well, there's an issue there. Let's face it. The health sector is a business. And you want people to ask the sensible questions. Is this right for me? And does it have to cost that much money?
So let's turn nationally to Medicaid. You know, as the new Republican majority crafts their first budget, there's at least talk that they may look to Medicaid for reductions. You know, one idea is variation on a block grant, a per capita cap that would cap the amount of money that states get on a per person basis. What do you think Medicaid's a reasonable target in these budget discussions? Should it be a part of it? And do you think a per capita cap would be a reasonable way to go?
Well, I don't think anything like that's going to happen anytime soon. So
How
we're
come?
only talking theoretically.
Yeah.
But certainly the problem with the current Medicaid program from an incentive standpoint for the states is that this matching rate business encourages the states to find you know, creative ways of, it's called creative financing, but it's actually creative billing for the federal government. So provider taxes and other kinds of gimmicks that have never really been stamped out. The states are always one step ahead of the federal government on this. We need to have a more honest accounting of the money, quite honestly. A per capita cap type of idea, which says we're going to calculate. I don't think for the general Medicaid population. I think you have to do it by types of patients, because there are some categories of patients who are very expensive, some who are, frankly, they're healthy, they're just poor. So you have to have a very sophisticated program if you're going to go this way. But certainly something where the principle is that just because the state found a new way to build the federal government doesn't mean, without producing any extra services, doesn't mean they get more money.
And you said you don't think this is going to happen. How come?
Well, a couple of reasons. One is that Barack Obama is the president. And the other one, probably more important, is that Republicans can't agree on a lot of things, and this will be one of them.
Just like Democrats, huh?
Exactly. Well, you know, they all come from states. That's one of the issues.
Judy, we've been talking about per capita caps in Medicaid for a long time. What do you think would happen? What would be the result if we went that route?
Well, just to take a step back, when you asked the bigger question about whether we need to be limiting Medicaid costs or spending in some kinds of arbitrary ways, I think the answer is clearly no. Medicaid on a per capita basis has always been much cheaper than any other insurance program, kind of getting by on the cheap, getting access with a limited set of providers. Its growth is now, the overall spending is driven by the fact that we have too many poor people. I'm going to do something about that. The per capita cost growth is very slow, as it is in the rest of the system, and so this just seems to me ridiculous. And when you go for arbitrary caps, you ignore developments or put states at risk for developments that increase costs in the state, that like Sovaldi and other high-cost drugs. We have our experience with in Medicaid's being able to respond to the AIDS epidemic, and the other epidemics can emerge. I mean, and as Joe's describing, it's really a complicated matter to design something that's just right. So I think that it is always a bad idea, and that what we need to do to contain Medicaid cost growth, as with the rest of the system, is to do it system-wide. We need to continue to develop more efficient ways to pay providers and to hold them accountable.
You think that's going to happen anytime soon?
I think we're working on it.
Can I add something to that? I agree, absolutely. We need system-wide improvements, not necessarily driven by government, but we need improvements from somewhere. But it's still the case that states have this incentive to cheat, in essence, and we really can't ignore that. That's a real problem. Also, there's no reason why we need to lock beneficiaries, patients, into that program. If they have an opportunity to join what I think of as mainstream healthcare, which I include the exchanges as part of it, why not let them take their subsidy and go with it? Why not?
So I think there are a couple of issues there. One is the issue of states drawing down as much federal money as they can has long been a concern. But if you're looking at the slow growth rates, it does not seem to be a big deal right at the moment. And so it seems to me that to address that, what seems to me not a problem in a way that would be, I think, highly problematic, arbitrary limits does not make sense. The second issue about whether everybody should get mainstream care. It depends. Hey, I'm for that. But I think the challenge is whether they will have enough to shop with, whether the benefits are good enough, whether what the cost sharing looks like. What concerns me is that shopping arrangements can be highly problematic if you don't have enough to shop with, and if the coverage you get is not regulated. So Medicaid's got its problems, but people are still entitled to a range of services under the law that it enables them to, for the most part, get coverage when they need it.
Just an arithmetic point. Nobody should feel comfortable just because the growth rate is relatively low. There are a whole bunch of reasons, but the arithmetic reason is that if the states have optimized their ripoff of the federal government, then they can't. It
can't get worse.
They can't get more.
Right,
exactly.
I can live with that.
And so I don't think that's evidence whatsoever that they're not taking excessive advantage of a system that is incredibly weak.
Okay, we promised no math, so let's leave that one here. You both were talking about this question of putting people into quote-unquote mainstream coverage who may have been in a public program before, and we're facing exactly that decision now as the Child Health Insurance Program sunsets, which would require children covered through that program to be covered in either Medicaid or in marketplaces in some cases, or in many cases be uninsured. Judy, do you think, now that we have the marketplaces, is it still necessary to have CHIP?
I think that there are concerns that have been raised about the adequacy of the benefits for children when we know that cost sharing is higher in the exchanges than it is in CHIP, and so that is a matter of concern. The exchanges are still new and working things out, so I don't mind not doing that right now. But I think that the bigger issue with the need for the reauthorization of CHIP is that the lack of Medicaid expansion in many states, and the fact that in CHIP, whether or not you have the parents have employer coverage or an offer of coverage, they're covered. Under the ACA, if there's an offer to a parent of coverage for the family, then they are not eligible for subsidies. And so whether or not they can afford the family coverage, I think everybody in this room is familiar with the family glitch. That's a real problem. So the estimates are that if we don't reauthorize CHIP, we lose coverage for about 2 million kids. That's not acceptable.
Joe, would you reauthorize the program?
Well, I think there's an opportunity to actually make some reforms as part of that. I think that there's a lot of support on both the Democratic and Republican sides to reauthorize it, but let's not reauthorize it just the way it is. There are some real opportunities. Again, my theme is to try to integrate the subsidies to understand what we're actually doing here. And I happen to like the CHIP principle a great deal. If I were, when governor's not good enough, it's probably emperor of the universe.
We'll get back to you on that.
Exactly.
Yeah.
But the CHIP principle, where you distribute subsidies through that kind of a mechanism, it's kind of a block grant mechanism to the states, and then have the states really take charge. I think that's very important. I think that's one of the problems with Medicaid, that it's supposedly a state-run system, but they have to go to Baltimore every time they want to make any changes. So I think the principles behind CHIP are actually more sound than the Medicaid program.
So just to be clear, and where we disagree, the principle of a block grant as opposed to an open-ended federal match is, to me, completely unacceptable, because it leads to inadequacies of the dollars to be there to follow the people and the service costs. So in that sense, I think CHIP is and remains highly problematic, but it is providing coverage in ways that I agree that states own and are proud of. They like their programs, and we can't get rid of that unless we've got something as good or better for people.
And how do you think CHIP's worked out? Has it worked out better or worse than you expected?
It worked out better than I expected. If you remember the early years of CHIP, the money was not in the right place, and states were running out of money, and other states had too much money, and that's a problem with block grants. And I think that the attractiveness of the program over time to state advocates and to states and to providers led to a working out of some of those problems, but does not mean that the block grant is a viable mechanism over time.
Well, enough of this happy talk. Let's get to some tough issues. The King case, King v. Burwell, now before the Supreme Court, a case that I never thought would get to this point. I don't know about the two of you. If the court sides with the plaintiffs this spring, it would eliminate subsidies in up to 3 dozen states that do not run their own marketplaces, but have instead deferred to the federal government. Judy, play out what you think would happen if, in the marketplace and for the uninsured, if the court sided with the plaintiffs.
So first, I just want to cross my fingers once again, and it's the Supreme Court has done some surprisingly good things as well as surprisingly awful things, and so I'm rooting for a surprisingly good thing, and maybe bad things won't happen, because if they find it is the plaintiffs, right, that means it would go bad. It seems to me it's a frickin' disaster. It's on good days, I like to think that we're creative, that the administration is creative, that the Republicans in the Congress have indicated that they recognize that there's some serious issues here if coverage disappears, and so we'll find a way to fix it. But that optimism never lasts very long, and it is really highly problematic. It's an easy fix in the law for them to say what we meant was subsidies apply in all states, but that would be hard. So when you think about what it means, if they can't find ways around it, or which they might for some time, and miraculous agreement in the Congress to fix it, you need all three legs of the bloody stool for this complicated system to work. You need the rules on preventing discrimination based on pre-existing condition and rates for everybody the same, and you need the subsidies to make that affordable, and the mandate to make sure that you get a broad enough pool. And if you don't have the subsidy leg, then the rest comes apart, and nobody knows that better than the insurers. I think that would be highly worrisome to them, and I'm hoping that maybe that attitude prevails, and that the court recognizes the problems, or recognizes what the law really says, and that we don't have to go that route. Because premiums would not go up just for subsidized people; they go up all across the board, and the whole death spiral unravels.
So, Joe, I'm guessing you agree with what would actually happen if you lost the subsidies, but tell me if you don't. But what happens politically then? What does Congress do?
Well, this is the classic case of the dog that caught the car. He was chasing the car for years, finally caught the car, and now what do I do with it?
That's exactly right.
And so I think it's finally beginning to dawn on elected officials of both parties, actually, but Republicans, that this is big trouble politically. I mean, forget about people. Forget about health care. What really matters is, am I going to get reelected? That's the issue. And so there are all kinds of machinations that people are imagining. I tend to think that now, of course, the administration, stiff upper lip and all that. So they're saying, no, of course not. We know the Supreme Court will recognize the truth of the matter, and there will be no workarounds. Well, that's baloney. There will be workarounds. The most obvious sort of thing would be to decide, because these are the administration's rules anyway, just decide that an exchange isn't nearly the elaborate thing that it seems to be now.
But some states will still refuse to go along.
Right, exactly. But I think the other issue is, again, it's kind of a little nerdy issue, but it's really matters. Suppose that the Supreme Court actually does side in that direction. Well, so that on that day, CBO is going to say, oh, okay, well, that means that money was never going to be spent. And I forgot to look it up, but it's a lot of money. It's certainly hundreds of billions of dollars over a long period of time, and it's a lot of money just through the end of this year. And so if Congress wants to do a fix, that's a problem. If it's decided that they have to pay for it, because believe me, they don't have any pay for us for that. Now, there are lots of ways you can get around this, none of them which have been tried, and one of which it probably wouldn't be acceptable politically. You can't just tell CBO score it as a 0, even though I think that is kind of logical. But there are other things. So there's an interesting political problem here on top of the real problem that I think is not going to happen. Let me just speculate what could happen. I think that the first thing that will happen is the insurers will say, okay, we're not doing anything. We're not going to move. We're going to wait, because there's too much money at stake here. They don't want to disrupt absolutely everything. They want to hold on to these people. This is business now. And that will give, leaving aside little things like, August recess, which is very important in this town. You probably know that Supreme Court decisions take effect 30 days after the decision. So, interestingly, if they decide, as everybody thinks, at the end of June, there you are, July. You got a month to do something, guys. Now, Congress being what it is, I'm not sure that they would actually be able to do that, but I think before the end of the year, they will somehow find a way to resolve that problem. There are a lot of ways to resolve it that might actually involve some changes that I think market-oriented people like myself would admire.
Like what?
Well, for example, you could have a deal whereby states that didn't want to do this could be exempted from all of the ACA rules and requirements, but then they still get the responsibility of having to deal with all these people. They just have to do it their way. In other words, truly localize exactly the same objectives down to the state level. That's one possibility. Now, I'm not convinced that that's any cheaper, but I am convinced that politically that would be very interesting to Republicans.
So I wonder if what you're raising, because as you put forward a really short timeline, I wondered if when you think about fixes or what they might get from, as they try to fix this,
Right.
It seems to me it runs counter to doing it on a really fast time schedule.
Well,
And
right.
so-
Well, actually, everything runs counter to doing anything on a fast time schedule in this town. The other thing is, it's interesting.
So Joe, do you think it's possible they could buy themselves some time by continuing the subsidies for a while, Congress?
Possible.
Well, but continuing the subsidies for a while requires a legislative action.
Well, that's what you're saying.
But
That's
a
what
less complicated one than
Maybe-
changing the structure
Well,
of the law.
so the question is there a moment of leverage? And if so, who has it? Because on the one hand, you might think, well, gee, Republicans are going to be in the driver's seat because, Democrats really want this to continue on, and so they can demand X, Y, and Z. On the other hand, you look at the president's State of the Union address, where he clearly said, I don't care what you say, I'm going to do it my way, and if I don't agree with it, it's going to be vetoed. So especially if he's not too concerned about Democrats' electoral chances, it might really be on his side rather than on the Republican side. I think it's way too close to call, but it's going to be interesting to watch.
Sure, you've sat in a Democratic administration. How do you think they'll look at this?
It seems to me that they can't trade away a lot. I think that they have to be looking at workarounds. I think they have to keep the subsidies coming, but I'm not sure they're going to be dealing in the way that Joe's. I mean, I think the way to do it is if it's. I liked when you were talking about the possibilities of a deal, or some trade, or some fast action. I think the short-term one makes the most sense, and then they'll just keep fighting another day or look for their leverage. But I don't see a major negotiation on the future of the law.
Remember in the good old days, I hate to say it, it was decades ago, this would have been a great opportunity for a deal. But not anymore.
We're not in those days.
We're not in those days anymore.
It does strike me, that this is not unlike some of the fights we've had over government shutdowns. And Joe, you raised, who's got the leverage here? I would flip it around. Who would get the blame here when people lose coverage? Is it the governors of the states that are refusing to set up a marketplace? Is it the White House because it's their law, or is it Republicans who have refused to make small changes to the law to allow
Which is what you're saying about when you ask how that's what the administration's goal would be, to put the blame on the other side, obviously.
Right, and I think they have an advantage there because, of course, it was I assume it was Republicans initiated the suit. But certainly a lot of the rhetoric from Republicans up until this month have kind of lined them up to, oh, you're the people who did this. But you bring up governors, and it is actually the local officials who are going to apply, I think, maximum pressure to their representatives in the House and the Senate. Because, in fact, they don't want to be stuck having to fix it.
That's true.
And in fact, they will have to look like they've done something if Congress doesn't act. This is the classic hot potato, and nobody wants it.
That's true. God, it's the dog that cart the car. It's a potato.
all kinds of metaphors. Joe, there's still talk of repeal by Republicans in Congress. Do you? Is repeal in the cards? Is it too late? Let me ask it differently. Is it too late to repeal this law?
It's never too late to take a vote on anything.
That's not what I asked.
Oh, oh, okay. Well, you know, the reality is, I don't think the expression is the law of the land is the way to look at it. Yes, it's the current law of the land, but the question is, what is the it? So I believe that it will be changing. Might not be changing this year, probably not. Might not be changing next year, but it will be changing. I think the next president will be making a lot of changes. Yeah, the general outlines are going to be there. I mean, certainly, I think Republican leadership have already said that a number of things that they just wouldn't touch anymore. They're certainly not going to go back on guaranteed issue. I think that would be a political suicide for anybody at this point. They're not going to go move against the kids up to age 26 or non-working adults up to age 26 staying on their parents' coverage. Nobody's going to pull back on that. That's, of course, a middle class kind of a thing, so you don't pull back on that. And other more significant things. The idea of exchanges, golly, the principle is really good. It doesn't have to be run by the government. A mechanism whereby people can look at choices, I think that's going to be in the cards. I think we have to work on getting it so that people can actually understand those choices. But nonetheless, I think that's a principle that I think is going to be there. Heck, it was there before. I mean, eHealth, private company, was doing it as well as they could, and I think quite well. Small, relatively small business, but nonetheless, they've been doing it for 10 years. So a lot of these ideas are there. The other part of this is
sounds like the Affordable Care Act. What is it that you want to repeal?
Okay, so why does everybody have to buy a super expensive health plan? Why does the federal government have to regulate to such an absurd extent the premium structure? I mean, I think liberal analysts also agree that was a mistake. Look, it's a business. You can't put them in a box and then say you also can't charge actuarially fair premiums after you've told them to stop doing everything else that they do.
Well, let me get Judy's response to those. So how would you feel about, let's say, relaxing the requirement for minimum coverage? I assume you're talking about the essential benefits and the minimum actuarial value, a 60% actuarial value for a bronze plan, and relaxing the rating rules. Charge an older person no more than 3 times a younger person, charge women and men the same rate. Judy, how would you react to relaxing?
I would feel very sad and angry. I don't like those at all. I mean, when I've looked at the alternative proposals, I think some of which you've participated in, Joe, the idea seems to be to give people a credit and then or give them some money, which may or may not be enough, and then have, say, whatever they buy with this is fine because they're choosing their own coverage. My objective is to get people meaningful coverage that covers them when they're sick. And I think that the proposals are just willy-nilly, and we've had some experience with that. I think it's, now, 25, 30 years ago with a child health insurance credit that people got with no rules on the credit, and what they bought was crap. I mean, so, that I have no interest in spending public dollars on crap, and I have a strong interest in getting people meaningful insurance coverage. So I think absent the rules, we haven't achieved the objective.
Well, you're implicit in what you say is that you really believe that we should be paying hospitals that much money, and that they are efficient. They're not efficient, and it's not just hospitals. The health sector is very inefficient. That's point number one. I'm not arguing for price controls.
I was ready to make a deal with you here.
No, not at all. But I am arguing against having people feel that the sky's the limit, which is basically where we've been. And Medicare is where you'd start to solve that problem, because the sky is the limit in Medicare. And bluntly, Medicare has shaped the private health system in its image to a very large extent. So we need to have meaningful reform of Medicare, but the idea that when people say that low-income people are getting subsidies for insurance, well, they're actually not getting subsidies. Insurance companies are getting subsidies to cover people. That's a little bit different. And in fact, individuals don't ever see the money. So this is really, again, government and big business at work. And the population is, once again, in the health sector, kind of bystanders in all this. And I think people need to take more action, more control, and they also need to be more responsible for their own activities that contribute to their health.
Let's talk about healthcare costs for a minute. So the President said in the State of the Union the other night that health spending has been growing at the lowest rate in 5 decades, which is true. I think, Joe, you and I agree that part of that's the hangover from the recession. Yeah. But part of it are initiatives that have been taken in the private sector. Is part of it the changes in Medicare as well? Medicare is actually growing even more slowly than the private sector. How would you diagnose that health spending slowdown? What's behind it?
Well, of course, it's not easily diagnosed. I think the Medicare slowdown doesn't surprise me in the slightest. Seniors are acutely aware of what's going on around them, more so than young people, I strongly suspect, especially when it comes to cost. And seniors haven't seen a raise in their Social Security payments in years. So it isn't too surprising to me that when they hear all this talk about bad times, which we had legitimately bad times, that they wouldn't reconsider a lot of things that they were doing. Again, considering that prices were still going up on the things they do buy, but their incomes were not going up. So that's not a big surprise. There will be some upward adjustment. Economy's getting better. I think seniors will, again, get kind of back into the mode that they were in, and the rest of us will too. When you have good times, how do you spend your money? Well, one of the things we spend our money on is better health care. There's no question about that. But how much did the ACA really contribute to the slowdown? It's kind of hard to argue that much has happened yet. I mean, remember that you have two things going on that are in opposite directions. On the one hand, it's mostly actually Medicare cuts to hospitals, physicians, and everybody else. There really isn't much else.
Which has taken effect.
Well, not as nearly strongly as it will in a couple more years, and I think that's the issue. So what we're really seeing is kind of pretty standard cuts to everybody, including physicians. We haven't seen the really strong ones, and those are the kinds of cuts that I think the system can live with, and that I think they don't disrupt healthcare for seniors. But you get to go down a few more years, and those cuts will grow. And as they grow, that can be disruptive to seniors' health care, and is certainly disruptive to the average politician's desire to get reelected. So I think that's going to go. As far as the experiments, the ACOs, and the other ideas, it's way too early. They're very small scale. The only other thing that I think is a legitimate effect of the ACA, which I'm sure, I feel confident took effect in 2009, was the threat effect. Insurers and the health sector recognized that President Obama was going to be President Obama, and something was going to happen, and if you don't know what it is, you batten down the hatches. And so I think that there were some preemptory adjustments that were taken. There were some increases that were not taken, and they've hung on I think for good reason. But I'm worried that 5 years out, those reasons will all be gone, and we will have, assuming that the basic idea of very large subsidies to low-income people for insurance remains with us, then we've got this huge bolus of demand that will also be driving it. And I'm not saying that's bad, but what I'm saying is that I think health spending will jump back up.
So Judy, I heard you ready to take a deal from Joe for price controls.
I was absolutely ready, because I think what Joe's earlier comments make very clear is that he and I have very different issues or perspectives on how we should control costs in the system. I agree with you totally that it's providers. What we pay providers drives the system. I just disagree with you totally that the way to deal with that is to have people have more skin in the game when they're paying for care and for insurance coverage. They've got plenty of skin in the game. What we're seeing in terms of the deductibles in health plans, they're going up. Not only are they high, around $2,000, I think, on average in the marketplaces, but they're going up in employer-sponsored coverage. Healthcare is becoming increasingly an out-of-pocket responsibility. Plenty of skin in the game. What we need, and you can't put enough skin in the game without eliminating insurance to ultimately have somebody, the third party, the private insurer, the public insurer, pay the bill. And so what's needed is responsibility on the part of the payer to pay in a way that keeps costs under control. And I think that the provisions in the Affordable Care Act to pull back on what we're paying on overpayments in a variety of ways is clearly contributed to the fact that there's less money sloshing around in the healthcare industry, along with higher deductibles and other things too, so that the providers just haven't been able to spend enough. And yeah, they'll be looking, I think, to bring that back, but I think we have to keep those controls in effect in the public programs. I think that I agree with you that we're very early stages, but that's not quite what you said, but that's the way I see it, in terms of changing the way we pay providers and trying to achieve better value at lower cost. I think that is definitely a work in progress, and we're going to have to see how that pans out. But I think that what we need is greater responsibility on the part of all payers, and ideally collectively, to keep what we pay providers in check, and that's the way to control costs, not to have people pay more out of pocket. They can't pay enough and be what we'd call insured.
So I'm pretty sure we could do this for another hour, but I know we can't. So one final question, and keep this short. So the next president came to you and she asked you in 30 seconds. What's our biggest unsolved problem in healthcare? What do we still need to do?
Well, we did plenty of work for people in this room. We haven't remotely solved the problem of access to, affordable access to meaningful health insurance and to meaningful coverage and to affordable care. I learned from, and now your colleague, my long-term colleague, Karen Politz, that we needed to assess the system on the basis of adequacy and AAA. Adequate coverage needs to be adequate, affordable, and available to people regardless of health status. I think we've made some progress on the availability, because the insurers can't discriminate based on health status as much, although we need to watch it. I think, as we've discussed, we've got some real issues on affordability and the adequacy of the coverage, and that's true whether in the marketplaces or in employer-sponsored coverage. And I think we need to keep working on all of that. And I think that the biggest challenge we face in getting, you told me to keep it short, but okay, so this is it. I think that the biggest challenge that we face as advocates for getting people health care when they need it is that we've gotten a miraculous reform, but we retained and built it around a private health insurance system that has perverse incentives, is not designed to control costs, and is a bitch to navigate. And And we got that because our politics does not put a lot of faith in government, and we don't give government the resources they need even to manage this extremely complicated system. So I would say that our biggest problem is that the American political system does not trust government, and God damn it, we got to do something about that.
So Joe, same question. The president, and I'm guessing in your case it would be a he, this time around.
It might still be a she.
There might be. What's our biggest unsolved problem still? What's our highest priority?
Well, I'd say it is the structure of healthcare. It is the failure to recognize that there is a connection between people and the healthcare system, between people, their own activities, and their own health. I think ultimately that is the problem. You could always increase taxes on everybody, not just the rich, on everybody, and pour more money into government coffers and hope that the committee of wise men and women on the Hill, who've done such a fine job so far, will have great answers for you. But that's unrealistic. If you're really going to see change, it's going to happen where the change has to take effect, which is out there in the health sector, among the people, but also among the entities, the health plans, the hospitals, the medical societies, and so on. They're the ones who are really going to create change. The government can trigger some things that might push them in a good direction, and often triggers the things to push them in a really bad direction, and more often than not, triggers things that they can't anticipate what direction they're going to go. And so I think that we need to think a lot more about how we get consumers involved, how we get people as patients involved, how we get people as human beings involved in this, and have them have more of a say in the matter. I'm not arguing against government involvement. It will always be there. It's a big industry. I'm not against regulation, but I'm against regulation that is excessive and that can't be changed when you find that it doesn't work the way you imagine it would. And unfortunately, that has been the hallmark in the health sector for quite a few years.
Well, we'll see which of you gets asked the question in a couple of years.
If they're smart, they won't ask either of us.
Well, as should be clear, it's not quite time for us all to go home and congratulate ourselves. We'll keep reforming reform. And the good news is it's job security for us and for all of you out there as well. So please join me in thanking Judy and Joe.
Thank you, Larry. By the way, what'd you do to your finger? Have I seen that before?
No, this is recent.
Announcements here for the final part of the day. Right now, beginning right now, in the Columbia room, we're showing the remote area medical documentary for folks that want to see that. It's in the Columbia room, which is right around the corner and is starting right now. At 6:30, we will return to this room for the awards reception. So be back in here at 6:30 for the awards reception where we will honor the Health Action consumer advocates. Thanks so much.